I would like to move to our next speaker. Maritza Bond, MPH, MDiv, is Director of Health of the City of New Haven, and is obviously in that post is deeply involved in maintaining the health of everybody in New Haven, and is a public health scholar practitioner, a doctoral candidate in the Doctor of Public Health program at the University of Illinois, Chicago. She has over 20 years of leadership in municipal health systems, health equity policy, cross-sector partnerships across Connecticut. As I've mentioned, she serves as the Director of Health of the City of New Haven, an adjunct professor in the Masters of Public Health program in the University of Bridgeport. Her work and scholarship focuses on community-based public health, advancing health equity through interdisciplinary approaches. Please, Director Bond, please join us on the stage.
All right, can you see me? There you go. In New Haven, I know the risk of your chronic disease, not by your family history, not by genetics alone, but by your zip code. That's the operational reality of leading municipal health departments in 2 of Connecticut's major cities. I served as the health director, as noted, of the city of Bridgeport before stepping into this role 6 years ago in the city of New Haven. Along with service to rural and suburban neighborhoods, I've spent more than 2 decades inside Connecticut communities that carried the heaviest burden of the disease we are here to discuss about. Before I go further, I want to share a story. Toward the end of my abuela's life, she had many cravings, and my job, the way I understood it, was to appease every single one of them. She was 88. One afternoon, she asked me for a snack, and I was on a mission to get it. I went to a local corner store in Fairhaven section of New Haven. This is actually the neighborhood that I grew up. And standing in that store, in the bodega, I was struck by 2 things. One, the prices. Overpriced, the way that they often are in neighborhoods where people have no other choice. 2, the food on the shelves. Ultra-processed, sugary, packaged, row after row after row. And I thought about what would it take for a family in that neighborhood to consistently choose the healthier option. Not the choice itself, the structural conditions to make the choice possible. Because too often, families are left choosing what they can afford, and the income of margin, the transportation, the time, the access. I also thought about the work we've done years earlier in Bridgeport. As the health director there, we partnered with local corner stores and bodegas to stock fresh fruits and vegetables, and we connected with local farmers, and we even helped them with their awnings and their storefront marketing, because we knew that visibility and the dignity in the storefront mattered just as much as the inventory inside. I tell that story because some of the most important public health experiences are lived outside of a clinic. They happen at the counter of a corner store. They happen in the hour of working parent that does or does not have. And I'm asking each of you in this room to see the public health crisis of liver disease through the same lens, so that we, each of us, that can do the best work that we are in our respective fields, and for those who need it most. This room representation is really rare, and I'm proud to see that the state working group produced 20 impactful recommendations that this day was built from. Senator Anwar and Representative McCarthy Vehe, Dr. Miho and Dr. Bonini and their colleagues made this possible, and no other state has taken this step. And that deserves a round of applause. The working group's report documents something I want this room to sit with. For an individual with the advanced form of this disease, family members carry a 12% higher risk of also developing it because genetic and environmental factors concentrate in households. That finding alone should tell us the intervention cannot only be clinical, it has to reach the household, it has to reach the environment, it has to reach the street the household sits on. Hispanic and Latino adults in the United States carry a 50% higher relative risk of developing fatty liver disease compared to non-Hispanic adults. That is alarming, especially coming from a Latina woman who's on this stage. The work this group reports names Hispanic heritage as a standalone risk factor. I want to be careful how we hold that. Our food culture wasn't built around the corner store. It was built around the kitchen. I was in that kitchen as a young child, standing next to my abuela who raised me, learning the recipes I am still proud of today. It was built around sofrito. Anybody know what sofrito is? I'll describe it. Simmering on the stove before anyone in the house was awake. See, this recipe is made out of recao, cilantro, garlic, onions, ají dulce, which is sweet peppers, all that are grown from the earth. The foundation of every meal that followed, it was built around rice and beans, around meals shared across generations, at tables where no one ate alone. The risk factor is not our heritage. The risk factor was replaced by it. When a family cannot afford fresh ingredients, when a working parent does not have time to cook, when the neighborhood grocery is a bodega with processed foods, we're not seeing a culture. We are seeing a displacement of our culture. In Connecticut specifically, Hispanic residents are nearly 4 times likely to be uninsured than white residents. Bridgeport is 45% Hispanic or Latino. New Haven is 30%. Between those two cities, we serve over 275,000 residents, a significant share of the state's highest burden population for this particular disease. The working group's own report names the structural drivers: limited access to fresh foods in inner cities, multiple jobs, long working hours, night shift work, and critically, approximately 20% of patients with the progressive form of disease are not overweight or obese, as you just heard. The metabolic environment in driving the disease is even for people who do not fit the stereotype. This is what we in public health call the upstream drivers of disease. The liver is the clinical presentation. Metabolic dysfunction is the underlying condition, but the root cause is an environment shaped by decades of disinvestment in specific communities. Naming that clearly is not an indictment for anyone in this room. It is the accurate diagnosis of what must come before an effective intervention. So what I want to leave you all in this room are with 3 asks. First, bring local health departments in as a partner, not a downstream audience. New Haven Public Schools enrolls approximately 18,000 children. Our public health nurses are employed by the New Haven Health Department. They are in every single school. Our school-based health centers, who are funded and operated by the federally qualified health centers, serve as clinical partners for our families. Our community health workers are embedded in our highest risk neighborhoods already. We operate the Ryan White HIV services program, lead poisoning prevention, environmental health, and housing programs. This is the existing municipal health infrastructure that is in place already. And we present ourselves in these buildings and in the households where the disease is concentrated. The working group's recommendations on awareness and detection points to exactly this infrastructure. With the right resourcing, the right clinical guidance, and the right partnerships, that is where the opportunity lies. Second, build the referral bridge between community and clinic before we scale awareness. When public health professionals identify risk factors in the communities that we serve, there must be a functioning clinical pathway waiting, shared protocols, agreed screening thresholds, designated referral partners. Without the bridge, community detection is just documentation. Third, we need to engage the pharmaceutical industry on access now and not later. We know that the only FDA-approved medicine, and actually they're here today, is currently the only FDA-approved medication, but we know that it's also costly. We know that it's approximately $48,000. For communities already nearly 4 times more likely to be uninsured, awareness without access is not a public health intervention. The working group's own recommendations on treatment access specifically addresses affordability, which I'm grateful for. It calls the needs, the call needs a named owner, a timeline, and a convening of industry partners. Without affordable and accessible treatment, we're building an awareness campaign that will raise expectations we really cannot meet. Connecticut has taken a step today that no other state has taken. The communities most affected by this disease are in Fairhaven. They're in the east end of Bridgeport. They're in Hartford and Waterbury. They are in Willimantic and every rural and suburban community in this state where the burden of this disease is quietly rising. They are managing conditions they do not yet know they have. Environments that make prevention difficult. Our charge from this day forward is to make sure that what's built in this room actually reaches them, not as recipients of decisions made about them, but as the reason we made those decisions in the first place. The people that we serve cannot wait. Let Connecticut show the nation what public health leadership looks like. Let us get to work. Thank you.